Yes, so at this ASH meeting 2024, we presented an abstract analyzing the impact of extranodal disease at time of CAR T-cell therapy. So we categorized patients in three groups: patients who only had nodal disease, patients who only had extranodal disease, and patients who had both concomitant nodal and extranodal disease. Notably, when we looked at the baseline characteristics, the group with concomitant nodal and extranodal disease had baseline characteristics which were unfavorable. So there was a higher rate of patients with high tumor bulk, with increased LDH, with a poor performance status. So this is important to take into account. And these patients also had a higher number of extranodal sites involved at time of CAR T-cell therapy compared with the only extranodal group. What we saw in terms of outcomes were that in terms of both response rates and survival, the only nodal and only extranodal groups performed similarly. However, the both nodal and extranodal, the concomitant, patients with concomitant nodal and extranodal disease performed more poorly in comparison to the nodal and only extranodal groups. So there was a shorter PFS, a shorter OS, and a significantly lower complete response rate in these patients. And this could have been driven by the baseline characteristics we mentioned, or by the fact that they had both concomitant nodal and extranodal disease. We looked at how the number of sites involved at time CAR T-cell therapy impacted results, and we saw that as the number of extranodal sites increased, the chances of achieving a CR were lower, and the higher number of extranodal sites was also associated to a higher risk of a shorter PFS and a shorter OS. In terms of the extranodal site distribution, soft tissue and bone marrow were the sites that were more commonly involved. And finally, we looked at those patients who progressed after CAR T-cell therapy. We saw these patients had a high rate of extranodal involvement at time CAR T-cell therapy, and this increased at time of progressive disease to CAR T-cell therapy. Extranodal site distribution was quite comparable to the pre-CAR T time point, and we performed a network analysis highlighting the complexity of interactions between the extranodal sites and identifying some extranodal sites that were more highly connected with others, meaning that patients who had involvement of that extranodal site usually had other extranodal sites involved as well, and others which usually presented in an isolated fashion, such as CNS and breast. So this highlights that some extranodal sites, we identified liver and adrenal glands as having negative impact on outcomes as well. Some extranodal sites can impact outcomes, but many times the fact that patients with extranodal disease perform poorly is associated with the fact that they have a higher tumor burden. And this is very important when we are planning how to manage these patients.